Good morning. Now, after having gone so far, how to give a block, how to prevent complication, I'll be discussing one topic where we should know and decide whether we can give such a block or when they're on this medication. As ophthalmologists, we all know that patients coming for ophthalmology, large majority of them are on some systemic medication, including antiplatelets and anticoagulants. It is important that we should know how to deal with them, whether to stop or to continue, which is the better one. As we all know, we have a number of antiplatelet drugs. They are mainly classified on their mechanism or site of action. The most common, which we know, is thromboxane inhibitors, or we commonly call it aspirin. They are all irreversible platelet inhibitors. The only way of recovery from the effect is replenishment from the bone marrow. The other groups which we commonly encounter are ADP receptors antagonists. The most common drug of this is Dogrel, and the recently which have been introduced, which we may encounter in the future, is Prasugrel. And there are another third group which are important and commonly used by the cardiologists is glycoprotein 2B and 3A inhibitors, FCs, GMAC, eptifibrate, and tyrofibin. Their main importance being that they are very fast onset of action and very short duration of action. So reversibility is very fast and can be used as a bridging therapy when the patient is platelet and very high risk where you want to continue some form of protection from thrombosis. The rest are not common, so we will not be discussing. The first group, the first which we commonly encounter is aspirin or dispirin. It is acetyl salicylic group. I'm sure we must have encountered, most of us and many of us may be on this drug, and many are just for secondary primary prophylaxis without any risk. I'm sure some of our colleagues, Dr. Josna especially, takes dispirin sometimes when she travel for 15 to 16 hours. So there might be many other patients who come who take this drug as a primary prophylaxis. It is a complete irreversible blocker of cyclooxygenase or COX-1, which is commonly called. The dose we use is for prophylaxis usually 50 to 150 milligram per day, a maximum maybe up to 300 milligram. Its indication mainly is for a primary. Many times it's indicated or prescribed when there is a risk of vascular event or thrombosis. When it exceeds, they say literature says about more than 10% in 10 years period of time. However, the most common which the patient takes will be because of secondary protection or prophylaxis who had history of MI, who have undergone PCI, who had history of stroke. In such patients, usually cardiologists prescribe this drug to be taken lifelong or at least for a long period of time. As I said, irrespective of its half-life, the only way we can regain its normal platelet function or aggregation is that it have to replenish. Hence, if you want to have complete regain of platelet function, you have to wait probably for at least 4 to 5 days before you can safely say that probably the bleeding time should be normal. As long as literature is concerned, they say that a patient who is in this sprint coming for surgery, various surgery including ophthalmology, the risk of bleeding is slightly more, maybe up to 2 to 20% depending on various studies. The bleeding is slightly more in patients who go for cardiac surgery, but in other studies probably the loss is not much compared to who are not on this sprint. But recommendation is that and a patient who has taken very low dose, less than 300 milligrams, there is no contraindication for most of the surgeries, including ophthalmology. So, when a patient comes with on this sprint coming for surgery, if the patient is taking for only primary prevention, that means without any history of any complication, probably you can straight away stop drug for 5 to 7 days, then the patient can go for surgery. However, a patient, if he is taking this for secondary prevention, for prevention of stroke or previous history of MI and others, in such case, it's better to continue the drug. They say that the incidence of bleeding is not much high, whether you stop it or not. However, in specific surgery like intracranial surgery, they say that it's better to stop. The other groups of which we commonly encounter with clopidogrel. It acts platelet inhibition by ADP receptors antagonist. The indication is almost same like the dispirin. It can be as both primary or secondary. Most of the time it's because of for secondary prevention. The risk of bleeding is probably slightly higher compared to dispirin. The half-life is 4 hours, but as I said, it's not dependent on the half-life. For full aggregation, it takes at least 7 days. So if you want to completely get rid of its effect, you'll have to wait probably 7 days before the patient can go on the surgery. Commonly, this drug is used in combination with disprin. Singly, it's not used most of the time. So the recommendation is that when the patient comes of dual therapy of disprin and clopidogrel, if he is in a high risk category or high risk state, which includes within 6 months of incidence of stroke, MI, and the patient on insertion of bare metallic stent, or less than 12 months of drug-eluting stent, they say it's better. Only a vital surgery which are really essential should be done. If better, it's better to wait safety period. However, if the patient cannot wait for surgery, it's better to continue at least disprin. Sorry, if all the other surgery, better to continue both the drug and high risk stage. But however, in such specific surgery like intracranial surgery, they say better to stop at least clopidogrel, but however continue the disprin. However, the patient is not, if he have caused this high risk time and there is no very high risk, the surgeon is not very high risk bleeding, it's better, they say that stop clopidogrel, however continue disprin during the surgery. Prasugrel is the other it is a third generation thiionopyridine groups. They say that the efficacy for protection of all the secondary pyridine is much better than the previous group, particularly clopidogrel. However, as per the literature studies available to us now, the incidence of bleeding is slightly higher compared to the previous. However, the main advantage is that the effect is much more predictable than clopidogrel, because both of the drugs are products which have to be converted to active metabolite in the body. But thiionopyridines need conversion 2 times. So active metabolite we receive in the body is only 15 to 20%. However, prasugrel is only conversion for 1 time, and they say the effect is much more predictable. For all surgery, they say for prasugrel, if it is not a high risk stage of thrombosis, it's always better to stop for at least 5 to 7 days before surgery. As I said, these are the one group of antiplatelets which have very short half-life and very fast onset. The first FCA-ZMAC, they say half-life 30 minutes. If you stop the drug, they say at least 50% of the platelet efficacy will return within 48 hours. For tiorepiravir, they say by 4 to 6 hours, the effect will almost return to normal. Similarly, the third one. By itself, they are not commonly used for as prophylaxis. They are mainly used immediately or as a bridging therapy, since they are easier to control. But the main disadvantage of this drug is you have to give them IV infusion. So if you have to give a bridging therapy by stopping the longer acting, the problem is that you will have to admit the patient and continue the infusion and stop 2 to 3 hours before they undergo surgery. So many times people don't prefer for a routine surgery because you have to admit the patient. It becomes expensive for both the hospital as well as the patient. Dual antiplatelets are mainly used for patients who are on stent. So the bleeding tendency is higher compared to individuals. So one of the most common patients we find is patients coming with coronary stent. What are the recommendations? The recommendation is that if stent implantation is within 4 to 6 weeks, if it is an elective surgery, better to postpone till the patient comes to the safe limit of at least 4 to 6 weeks for bare metallic stent and 12 months for patients who are on drug-eluting stent. If it has exceeded that safety period, but within not the optimal one, then risk of surgery delay is greater than risk of the thrombosis. Better to proceed to surgery after at least 180 days of waiting after insertion of the stent. If it is no, we can delay the surgery until optimal period, at least bare metal for 30 days and drug-eluting for 365 days. In case the patient who have drug-eluting stent for 30 days but less than 365 days,